Hi everybody, welcome back to the channel. This is Dr. Wardwell. I'm a general practice doctor and soft tissue surgeon here at Viking Veterinary Hospital in Nampa, Idaho in the United States. The case we have today here is a young dog from a local tribal reservation that was found after the clients came home from vacation to have a broken humerus. X-rays show metal fragments in the area, so it's thought to be a gunshot wound. And due to the location and extent of the injury and the chronicity of the injury, it was elected to amputate the forelimb rather than attempt to repair the fracture. So that's what we're doing. We're going to do a complete forelimb amputation by scapulectomy. So we're going to just take the entire scapula off of the thorax and the limb along with it. When you're doing an amputation, it's important to remember you only need to cut through the muscles that are supporting the limb. So the muscles that cross the coxofemoral joint or the hip joint on the hind leg, and the muscles that are part of that thoracic girdle that supports the scapula on the front leg. So you don't need to just go in and hack through every muscle. It's going to take a lot longer. It's going to be more frustrating. It's going to be more trauma on the patient. So it helps to know a little bit of anatomy here. And it's not really difficult anatomy, but it's important to know to make your job easier and make things better on the patient. So right now we're cutting down through the skin and subcutaneous tissues right along the spine of the scapula. And we're going to take off the two thin muscles that are attached just right directly to the spine of the scapula, the omotransversalis, omobrachialis muscles. Underneath that is the supraspinatus muscle. It's a big muscle attached right down to the scapula, but that muscle does not help support the scapula onto the thorax. You don't need to do anything to that muscle. So just an example of something you would encounter that you don't need to deal with at all.
To know the muscles that are involved with putting the limb onto that spot. So in this case, we're going to take the...
And so I'm using electrocautery or electrosurgery here to cut down and dissect through the muscles. It really just helps a lot with hemostasis, with preventing bleeding. And I don't use the cut function. I only use the coag function. The cut function will cut very quickly, but it doesn't really have any cauterizing properties. The tissues will bleed if you cut through something, some kind of blood vessel. So using the coag function, it cuts a little bit more slowly, but it typically saves you time because you're not having to deal with a whole lot of bleeding.
You're seeing is just stimulation of the muscles here by the electrocautery, making them contract. So it's not.
And here I'm just trying to increase my exposure a little bit more. I didn't make my incision up quite high enough, and definitely want to be able to see everything that you need to see. Again, makes your job easier, makes the surgery safer. Incisions all heal the same. Make your incision nice and long and get to what you need to see.
Back up here at the end. And now we're going to work our way down.
So now that we've transected those muscles, we'll extend our incision down through the axilla, through the armpit. And down here we've got a couple of muscles to deal with. The pectoral muscles, is the superficial and deep pectoral muscles. And on some dogs, these can be really robust muscles, especially on something like a pit bull or something like that that's really muscular. Especially that superficial pectoral can be really, really big. So it feels maybe like you're having to cut through a lot of tissue, or you might be concerned you're in the wrong spot, but that is normal for for some dogs' anatomy.
I realize my elbow is probably in the way.
Now, I'm not operating with an assistant, so it makes it a little bit tricky here. But I'll probably have my anesthetist put on a glove and hold that limb for me.
Yeah. Wow. Dog's skin does not conduct well. Once they get through the skin, it does.
So here I'm just freeing up any remnants of the muscles that we had previously been transecting. And then we can see my anesthetist in the background getting on a sterile glove to be able to help retract this limb for me. He's going to kind of pull double duty. It's nice to have someone scrubbed in to be able to help, but I don't always have the luxury of having an extra body available. But my anesthetist is very capable, so he can definitely monitor my patient and help hold this limb as long as everything is going smoothly on his end.
Now we have pectoral muscles to get through, superficial, pecs, and deep.
So now that I have someone retracting and putting some tension on these muscles, it's going to make it much easier to cut through. The more tension you have on any tissues that you're cutting, the easier they're going to fall away from each other. And especially true with the electrocautery.
Tends to be bigger.
And so I like to put my finger back behind the muscle belly to help isolate it, help me know I'm cutting through the right thing. But also in this area, we're going to be getting down here to the brachial plexus, where there's great big blood vessels and nerves, and we don't want to accidentally cut through anything before we're ready to. And as long as you don't have a hole in your glove, you won't shock yourself with the electrocautery. The tissue does get hot, so sometimes it gets kind of hot underneath your finger if you're cutting for a while and that tissue's really heating up.
Coag function.
And if you're not familiar with the use of electrocautery, any of the twitching that you might be seeing is just the electricity from the instrument stimulating the muscles to contract. So they'll twitch when you're cutting through muscle, and that's not the patient feeling anything or waking up. That's simply the electrical stimulation of the muscles from that electrocautery unit.
Patients on antibiotics, probably okay there. Bloodless field just allows you to see things a lot more easily, identify your structures.
So it looks like I'm getting down through the last of the pectoral muscle. There's probably a little bit more hanging on, but mostly now it's just this kind of soft connective tissue, after I get this last piece out of the way, that surrounds all of the components of the brachial plexus. So we'll be able to see that really well as this last bit of muscle releases.
When we get into the brachial plexus here, you're going to have your big vessels and your nerves. So right now I'm just going to break down.
So now I'm just switching to a hemostat to kind of bluntly dissect so you can see all of the individual structures. I want to identify the large vessels, the brachial artery and vein.
Big nerves of the brachial plexus here.
And the artery we will double ligate
Important vessels.
with a transfixational ligature and then just an encircling ligature. The vein, we can just put one good ligature on. And the nerves we'll inject with some bupivacaine before we cut them to try and reduce any residual pain.
So that's going to be our artery. It's just big.
And here I'm just trying to confirm the artery versus the vein. The artery has a pretty characteristic appearance. In this dog, it just looked a little bit bigger than I typically expect. It often appears smaller than, at least than I tend to anticipate for such a big, important vessel. But I mean, it is big, and it's very easy to notice if you're looking for it.
Take a little bit of time to kind of.
I was just a little bit surprised at how robust it appeared in this patient.
Sometimes there's a lot of branches off of some of the bigger vessels, and if you paying attention, it's, here's an axillary lymph node. If you're paying attention, it's easy to ligate them in one go.
And every patient is a little bit different. Sometimes you have additional branches off of the larger vessels. So the other reason I like to get in here and dissect everything out is not only so I can see where the important vessels are, but also see where they're branching, because sometimes you'll ligate the vessel and then realize you really just kind of ligated a big branch off of it, which is fine, but then there's another branch that you have to go back and ligate again. And so it just saves you time to be able to see that you're placing your ligature in a spot where one ligation is going to take care of everything you need it to.
It did not hold for very long. Cut this bad boy off.
So here I've placed clamps on either side of the artery and then transected it. And now I'm going to place a transfixational ligature. I've left enough of that artery protruding from the forceps that I can place the transfixational ligature here on the cut side so I don't make it bleed when I pass the needle through. And then I'll take the clamp off and place the encircling ligature just around the clamped area. And that shouldn't damage the tissue of the artery too much. The arteries have really strong walls and should be able to sustain being clamped and not just fall apart in that area.
Good measure. Where's he? Okay. Here's our artery. And then we'll ligate this guy.
Now that we've ligated the artery, we'll go in and find the vein.
There's a big branch. big branch coming off of this, and if we
Trying to dissect
ligated
all of the
here,
extra
we
connective
might hit
tissue
that
away
and
from
grab
it,
the
so
leg
we're
again. So it's not the end of the world.
placing a
It's just
ligature just around the
vein.
vein. It's going to ensure that our ligature isn't going to slip. We can make it nice and tight.
Hello.
Hello.
How goes it?
I was already sweating. So.
We'll use a ligature to transect that vessel, just so I don't have to ligate it on the limb side.
Does it?
I wouldn't trust ligature
Let's see.
alone to seal that vessel effectively. It's just a pretty large vessel. Now the vein, it probably could do. The artery, I definitely wouldn't trust it. In fact, I've tested it before, and it will seal for a second on some of these really large arteries, but then start to bleed. So I always ligate them manually, and then if I have ligature, I'll use that to transect them just for a little extra insurance.
These nerves with some bupivacaine.
So here I've pulled up some bupivacaine, and I'm injecting it into as many of the large nerves as I can isolate. And I'll just splash some around the area to hopefully infiltrate all the cut muscle bellies, any nerves that I hadn't isolated and injected directly. And we'll use more bupivacaine at the end of the procedure as a line block. Now, just like with the electric cautery, if you're noticing twitching as I'm cutting through here, it's just stimulation of the nerves as they're being cut will cause a little twitch. Again, it's not the patient feeling anything. We're monitoring the patient's vital signs. The heart rate is staying steady. The respiration rate is staying steady. These things would change if the patient was getting a little light under anesthesia and was beginning to potentially sense some of that discomfort. You'll notice as I go through, I'm still being careful about dissecting and making sure that what I'm about to cut is actually a nerve, because there are other extra little blood vessels through there. And so typically I'll cut all the big nerves, carefully dissect through, see if I can isolate any other specific structures, and then just use the ligature to get through the rest of the connective tissue, just in case there's any unexpected little vessels that we can encounter.
Alright, so we're going to come around the other side before we do this bit down in here. Yeah, you can definitely have more, at least broken.
Now that we've dealt with the brachial plexus, we can finish up our incision. Now, I'm making the final cut here down low and essentially making a circumferential incision around the base of the limb here. But you don't have to do that. In fact, oftentimes I'll take that incision, and instead of connecting it to the bottom of my
That's probably
original
fine.
incision, I'll go up and connect it to the top of that incision, make a large triangular incision. I'm doing this just to make sure I have enough extra skin. I will likely have too much extra skin and have to transect all that extra anyway. But I'd rather start with too much than not enough.
Delicious.
If you haven't done very many of these, it can make it a little bit more frustrating because some of the latissimus dorsi is going to be more covered up by the skin
Yeah.
if you do this. So you definitely don't need to leave that extra skin there in the vast majority of cases. It typically comes together really well without any tension really at all.
Holy shit, it took you like 10 hours.
Yeah, it's because
And
it's
she's
delicious.
like, but it's fucking amazing. I'm like, no.
So now we just need to take the latissimus dorsi off the back side of the limb. That's going to be connected down to kind of the back edge of the humerus and then up along the spine of the scapula on the caudal edge of it, kind of the opposite of what our
Now we're
initial muscles were.
taking the latissimus dorsi. Probably have plenty of skin. I could just put this out of the way, but
And I'm using ligature here because I'm
and then I don't
going to be
bring
encountering
it
the lateral thoracic vessel.
closer.
Which should be up here just a little ways.
On the back side, the latissimus dorsi is the only thing you need to take.
You can see how when I put some tension on that tissue
Scapular
by
muscle.
putting my finger underneath it, it really cuts very nicely. Your electric cautery is going to work the best when the tissue's under tension, when you have really minimal contact of the probe with the tissue.
Up here, maybe
And so if you
something
cut right on the leading edge
to the
of the
thoracic.
cut that you're working on, it's going to fall away a lot more easily because you can put a lot of tension on that and you can make very minimal contact with the electrode. That's going to focus that energy into one spot and help it cut more quickly.
These thin muscles, I really like just using ligature to do them.
Your electrocautery is also not going to work really well if the tissue is really wet. So if it's really bloody or really greasy. So make sure if that's the case, you're wiping it off if you're trying to use electrocautery. And if you're using it to control hemorrhage, you have to make sure to occlude the vessel that you're trying to cauterize
What do we got?
so you can isolate it and then cauterize it. So either
Okay.
blot over it and slowly reveal it and cauterize it before it bleeds significantly,
Nice.
or isolate it and grasp it with a hemostat or a forceps, and then you can actually touch the electrode to the instrument that's holding the blood vessel, and that'll cauterize it.
We're almost through the latissimus dorsi, and then we've got just one more muscle to go. Oh, it's all good. No, I think I was talking to you too, but I was talking to both. Talking to anyone that wanted to listen. Kind of the story of my life. Making sure our white balance was still good after moving here. Alright, now we'll peel this off the
They are dates.
serratus ventralis and cut through the rhomboideus.
So now the
here.
latissimus dorsi is
The rhomboideus
transected.
are muscles that go directly into
We
the
can
bone.
lift this up once more,
Just want to peel
and
the
now we've just got a little bit of serratus ventralis and rhomboideus muscle to
muscle
get
right
through.
off the scapula, and it's probably going to ooze, and that's okay. It'll stop bleeding once you get it off.
The rhomboideus is pretty robust on this dog too. And it's attaches just right down onto the scapula. And in fact, a lot of the blood supply to the muscle runs directly through the scapula, so sometimes it will bleed quite a bit because the blood supply is coming straight out of the bone, and it's not really easy to cauterize those vessels as they suck into the bone. So
Robust muscle.
if it starts to bleed, it's not the end of the world. It'll just do that until the limb is off. And at this point, any bleeding that comes through there is really just going to be stagnant blood that's remaining in the limb. There shouldn't be much blood supply to the limb at all.
So,
And eventually here we'll get through the last little bit of muscle.
There we
And
go.
there's the limb off.
there's the leg off.
You can see we've got a really nice clean surgery site here. Really no bleeding at all to deal with. And so
Gonna offer
now what we'll do is just reconstruct some muscle over the defect. So we'll oppose the omotransversalis and brachialis muscles to the latissimus dorsi and attach the pectoral muscles up to those to help kind of cover that spot up a little bit more and
You could definitely do that with the tendons, make the
help reduce some tension on that site. And then we'll close the sub-Q over that and probably do an intradermal closure on the skin.
this
I'll probably speed the video up a little bit for the suturing here.
muscles
So
here.
it's a little less exciting. So here we are. We're going to attach those muscles that were attached on either side of the spine of the scapula here. And I'm just using 2O PDS in a simple continuous fashion. So almost everything in simple continuous. It's fast, it's effective, and if you tie good knots and trust your knots and trust your suture, then it's just as safe and effective as any interrupted pattern. And I'll use continuous patterns on even on anastomosis of bowel. Body wall closures, things where traditionally a lot of people will use interrupted sutures. And that's not wrong at all, and you should do whatever's comfortable for you, but you definitely can get away with interrupted patterns, or continuous patterns like this. on just about everything, as long as you use good technique. And this is just a side note, but I'm noticing I'm using needle drivers that I really do not like. These are the Olsen-Hagar needle drivers, so they have a scissor built in, and the action is just so poor on those compared to the Mayo-Hagar needle drivers that don't have scissors built in. And that's what I use for almost everything. Our surgery packs include the Olsen-Hagars that I'm using. I have to open up a separate set of the Mayo-Hagars, since most of the people at our clinic prefer the kind with the scissors. And I must not have asked my anesthetist to open one for me. Some days it seems I just like to make myself struggle a little bit. So usually, especially on dogs, these come together in a kind of upside down Y shape or peace sign or something. On a cat, a lot of times the skin is so stretchy and there's so much extra, you can just do it in one single line. And you'll notice that there's been essentially no blood loss on this procedure, and some of that we can attribute to having the electric cautery. That definitely helps with a lot of the oozing from the muscle. And ligature is nice to help speed us up through the areas where there's going to be more bleeding that we can anticipate. But really, that's the important part of minimizing the bleeding, is being able to anticipate where things will bleed. Knowing your anatomy is pretty important for that. And luckily, there's not a lot of big things that'll bleed on this procedure. The brachial plexus structures are going to be your biggest risk of bleeding, and hopefully you know that those are going to be there. But there's some other not insignificant vessels like the lateral thoracic artery that aren't going to cause catastrophic bleeding, but it certainly can bloody up your field and just make it a less blood-free and elegant surgery. And having good visualization, not only from good exposure like we were discussing earlier, but also being able to see your tissues without everything being covered up with or stained by blood is also really important. So here I finished my subcutaneous closure, and then I did an Aberdeen knot, and I just kept my suture intact. I didn't cut it after I sewed the subcutaneous layer, and then I went straight into the intradermal closure. Just saves a little bit of time. And it puts a little less suture at each end of the incision, so you don't have a big ball of knots in one spot that causes a suture reaction. Again, not the end of the world if that happens, but clients will often come back and be concerned that they can feel something under the end of the incision, or that there's a little more of an inflammatory response near one portion of the incision. And those are all things that you need to be able to talk about, but if you can minimize those from happening, just one fewer issue you have to deal with post-operatively. And even though it might take a little bit longer to close with an intradermal closure compared to, say, a simple continuous, or maybe even skin sutures in some cases, like cruciates or interrupted sutures, or definitely not as fast as, say, staples, but they don't require removal, which is nice for the client, and depending on the patient, sometimes it's very nice for your nurses if it's not the world's most friendly or compliant patient. Also, it just looks a lot prettier, which sounds kind of silly maybe, but having a cosmetic closure is not only nice from an aesthetic standpoint, but it's the part of the surgery that a client can see. And so if your closure is sloppy, even if you've done a fantastic job, it still gives the impression to a client that, you know, maybe you weren't all that careful. If you show that you're careful on the part that isn't as critical, it's at least suggestive to an outsider that you must have been careful in paying attention on the part that was important. So it's a little thing, and it's really about perception. But perception is important. Clients need to know that you care and that you're going to be just as careful on every part of the surgery, regardless of how critical it is. Now we're trying to tie this knot in a way that it ends up below the level of the skin. And we'll pass the needle through and pull that knot underneath the skin. And that is that. We'll go through and inject a little bit of bupivacaine, local anesthetic, around the incision, just to add a little bit more numbing to the area and make the patient that much more comfortable when they wake up. And this dog should do well. Thank you, everybody, for watching. If you have any questions or ideas for other videos that you'd like to see, please comment down below. Thank you for watching. Like and subscribe, and we can't wait to see you for our next video.